Is a mental health disorder the best way to understand people's distress? As a member of modern society and in my role as a trainee art therapist, I guess I never really considered this question. I took the medical understanding as scientific logic, truthful and sensible. However, there is no evidence behind psychiatric diagnosis, and I'm left wondering if there is a more accurate way of understanding human distress and what impact a reliance on this medical model may be having on the people that have to carry around these labels of a mental health disorder. We live in a world that is obsessed with scans and blood tests, and where a quarter of us will experience difficulties with our mental well-being. Receiving a diagnosis can be a life-changing event. So who decides what your diagnosis should be? Is it an exact science, an educated guess, or a matter of language? Diagnosis is one of the foundations for psychiatry and is their way of making a scientific judgment about other people's behaviours. Though poor mental health may not result in a medical diagnosis being made, the World Health Organization states in 2009 that 1 in 8 people in the world are suffering from a mental disorder, identifying depression and anxiety disorders as the most common. The World Health Organization further define a mental disorder as being characterized by a clinical significant disturbance in an individual's cognition, emotional regulation or behavior. It is usually associated with distress or impairment in important areas of functioning. There are many different types of mental health disorder, and the NHS website here lists many of them. For a diagnosis to be made, an assessment will be carried out with a mental health professional using either the International Classification of Disease, or the ICD, or the Diagnostic Statistic Manual, the DSM. The International Classification of Diseases, the ICD, is on its 11th edition of a global categorising system for physical and mental illnesses published by the World Health Organization. The Diagnostic and Statistic Manual, the DSM, is published by the American Psychiatric Association and solely focuses on the mental health concerns, while ICD covers all parts of the body and mind. These manuals were designed to create a common language to be used across modalities of practice and research to explain people's symptoms and create a standardised set of criteria for diagnosis. The DSM and ICD currently are based on a categorising system that places people in boxes, and this has been noted to have damaging effects such as stigmatisation and discrimination. So is the way we understand mental health flawed? Is psychiatric diagnosis, as the only way of describing people's distress, the most effective way? Are we forgetting to respond to normal human emotions? And by pathologising people, are we doing more harm than good? Lucy Johnston, a UK consultant clinical psychologist and author of A Straight Talking Guide to Psychiatric Diagnosis, is one of the most high-profile and articulate voices trying to get people to think about illness and distress in a different way. She states it is important to note that despite their many differences, both the DSM and ICD are based on the same set of principles. That is the assumption that mental distress can be divided into categories of medical illnesses or disorders. She, along with other psychiatrists and even the clinicians that drew up the ICD and the DSM, such as Alan Francis, chair of the DSM-4 committee, admitted these categories lack validity or reliability. There is no medical proof or supporting evidence stating that they are deeply flawed and scientifically unsound. The medical diagnostic model has implications for all fields of therapists working with marginalised individuals, including art therapists, and to help me understand better others' views around diagnosis, practitioners and service users alike, I have spoken to Sharon McCormick from the Listening Centre. Sharon is the CEO of the Listening Centre and a counsellor based in private practice, with 30 counsellors and over 250 clients, as well as running a training centre for new counsellors where she has a big influence on the way we mould new therapists and their knowledge of the most effective interventions. She speaks passionately about her clients and works from a person-centred, holistic approach. She tells me about her patients' experience when they receive a diagnosis or are questioning the need for a diagnosis.
I suppose the first thing, the main theme in all of this topic is language. That's the central problem, I suppose. Then just picking up on the question, I don't call them patients, I call them clients, because when we call someone a patient, it's in the one down position, shall we say. Whereas I feel like I'm serving my clients, and when we talk about clients, it feels more of an empowered label. And patient is synonymous with the NHS. So I don't work in the NHS, so I never call anyone a patient. So that's the first thing I would say. The term mental health is splashed around like, you know, it's everywhere. And when I can, in my professional role as a therapist, because I do a lot of training courses with companies, and I'll say, just to let you know, I don't even use that phrase because it only defines one part of a person, which is their mentality. It absolutely doesn't encompass anything else of that person, like their mind, body, soul. You know, it just talks about what's going on above the shoulders, and that doesn't make up a person. So I just put that out there, and it's like, oh, okay, right. What do you say then? And I'm like, well-being, distress, which again, when you say to people, they're like, oh yeah, that makes sense. So yes, I try not to use that word mental health, although of course it's been embedded in my narrative, my language, my everyday repertoire, but I'm constantly checking myself and correcting myself. And then with clients, I tend to ask them, how does that feel? Explain what that looks like to you. I don't necessarily, mirror their language. I might just sort of paraphrase, rephrase it in a way that's non-pathologizing.
The biggest questions around the diagnostic model is, do these terms have any deep meaning or not? Serious conditions such as schizophrenia or bipolar at the diagnostic level are descriptors of a pattern of symptoms, and we do not have independent markers that can confirm this, unlike other diseases. It essentially means that you cannot tell if someone has it from looking at their body or brain. But can it also be helpful? Diagnosis can be the gateway to targeted and tailored care. It can give us a good idea of what treatments could be helpful, beneficial, and it also gives us an idea of the likely outcome. It can give virility, understanding and credence to your symptoms and the way you have been feeling, helping you explain what you have been experiencing to others such as family and employers, aiding such things as being able to claim benefits or being able to take time off work.
I suppose my thoughts are, I've got to kind of check out. I've got to do almost like a safety check of what their perception is of what that word means. Is it something they are seeking, or is it something that's been slapped on them? Because they're two very different spaces to operate in. So if they're seeking it, then it could be, that actually there's something wrong. I want to know what it is. It's that. So that's a validation, and it's very affirming when someone gets told it's this. So there's a lot of power in diagnosis. It contextualizes something for somebody. It gives meaning. It explains things. It gives an explanation, and so gives an awful lot of peace. It finally puts a full stop at the end of that. What is this that's happening to me? So I find a lot of clients that want it for those reasons. And then there's another angle to that, which is if somebody is seeking it, it's almost as if they're not taking ownership themselves of what is happening or what has happened, or even recognize that it does belong to them. Their journey, their story is theirs. And the problem when we get diagnosed is it takes away the story. It then becomes about the diagnosis. It doesn't become the story's lost and it's forgotten. And of course, the problem is with that is that the reason why the diagnosis is there in the first place is because of what's happened. So it's like dealing with when we got a broken bone and you put a plaster on that leg, and then it's dealing with the plaster. There's a problem with the plaster. No one looks at the broken leg.
Few people could afford to give up diagnosis entirely, as it is needed to access benefits and services, but there may be people who decide they do not wish to define themselves and their problems in this way. There are many campaigns and groups seeking alternatives to the diagnostic model and attempting to challenge stigmatising attitudes around mental health. The British Psychological Society has spent 5 years working on a project called the Power Meaning Framework. Writers include Lucy Johnston and Mary Boyle, as well as a consultant group of service users and carers. The power threat meaning framework supports all kinds of narratives of people's stories instead of diagnostic labels. It can help people create a non-medical, hopeful narrative about their lives and circumstances instead of seeing themselves as mentally ill. Encouraging us to ask, what's happened to you, not what's wrong with you. Art therapists are committed to the development of interventions to reduce mental health discrimination and stigma by using non-medicalised low stigma settings such as art therapy groups holding museums and art galleries, for example, as well as recognising art therapists and other healthcare professionals' power to either affirm or demean the self-identities of our client by rejecting or holding stigmatised beliefs or myths around mental health themselves. The International Journey of Art Therapy is making efforts to ensure that articles published follow anti-stigma code, with lived experience advisors reading articles and reporting back on ways they can improve the language and manner of reporting, ensuring the clients' and service users' voices are heard and their stories are recalled in a manner that reflects what they have experienced. Neil Springham writes, art therapy studies are increasingly using mixed methodologies and involve service users' perspective. However, more work is needed around the vague use of language, so we do not devalue the identity of our patients. The diagnostic model can often amplify the shame and marginalisation, leaving people feeling stigmatised. However, others have found them invaluable and affirming, even needed for treatment. But the worry around diagnosis by service users and clinicians is that you suffer as an individual but are treated as a category, and our diagnosis is seen before the person. But by researching this topic, it is clear that the world of diagnosis is changing, and professionals are beginning to recognise the need for this change, to see service users for their uniqueness. Val Hewitt, CEO of BAT, often uses the phrase, no learning without loss. With diagnosis so ingrained and dominant in our practice landscape, it will not be easy to change.
We are, as Joe would say, the change makers. We're the ones at the beginning where the earth is flat and we want to get in a ship and see if it's round. We won't be here when everyone knows it's round. And we won't be here when this model finally gets taken away and people actually start to listen to other people. But it starts here.